Great, thank you. I wish that the cameras were turned so I could see your faces. And I'm sorry that I can't be there with you today. The flights were all canceled into D.C. last night and this morning. I really appreciate Josh and Alex setting this up. I think they both gave excellent presentations to tell us sort of the groundwork of after-visit summaries and discharge instructions. I particularly appreciated Josh's insight into the trickiness of setting policy in this, or rules or measures, and how we assess whether we're providing good care for our patients vis-a-vis health literacy or providing the information they need. And I recognize that that's very complicated. I have been asked by the committee to discuss the title that hopefully you can see on the slides. I can't see the slides that you're looking at. It should be on slide 1, the title slide, the link between health literate after-visit summaries and discharge instructions and improved outcomes. Let's go ahead on to slide 2. I think it's really important to get this right. And as you all recall, I spoke out in favor of having this roundtable meeting the last time we were together because this is happening every day, every visit, every discharge, which I think is a very good thing, that all of a sudden when ONC and others made this a higher priority, it's required for meaningful use, it's now a part of our workflow in healthcare. And it's a great opportunity to improve care or to continue or create more waste. And what I mean by that is if we're going through the motions, as Josh aptly described, or even carrying out the checkbox, I would argue that that's a waste of our time. But if we can turn this into a value for our patients and our consumers, then we could really substantially improve healthcare. Next slide, please. So why is this difficult? Well, both Josh and Alex have covered many of these, but on the patient side, patients don't remember the details of the visit, their discharge diagnoses when they're leaving the hospital, or the treatment plans. From what Alex described, it's no surprise why they might not remember those. The other thing that was interesting as I was researching this topic is that patients don't feel able to manage their lives. They have low self-efficacy around medical issues. And I think Mark Williams is on the agenda, and I don't know if he's there, but he was a co-author on a paper that just came out a few weeks ago with Eric Coleman, really aptly describing how patients with low self-efficacy are even worse off in this situation, and we provide these difficult-to-understand materials, and it really is making things worse in some respects. On the clinician side, I would argue that we do not regularly ensure that patients understand what we're communicating. You all know this, that we don't understand the patient's skills and abilities very well and try to match our communication with that. We don't give very clear presentation, and we're very poor at giving a manageable volume of information. We like to spew forth, as I'm doing right now in this presentation. Our IT systems, so our EHRs, are really generally not designed to give information in a low literacy format, and Alex laid that out very nicely. Some systems are better than others, but in general, we're giving out a lot of different versions of these after-visit summaries and discharge instructions. They're complicated to dive through with the number of pages, and the notion of not knowing what's the difference between registered mail and certified mail is going on for patients in understanding these discharge summaries. And lastly, meaningful use. While I am a very big proponent of this aspect of meaningful use and think it is potentially a policy advance, it does mandate specific content, and I really appreciated Joshua's notion that there's a tension between trying to get into the details of what we need for these to be good and and then over-specifying them. So Alex laid out a long list of specific content, which is supposed to be in an after-visit summary. And in many cases, some of that content may not need to be there, and it may complicate things further. Next slide. I wanted to point out that although we're talking about health literacy a lot, that there's a big cognitive impairment issue that's going on, particularly at the time of discharge from the hospital. And several studies have documented a range between 30 and 43% of patients at the time they're leaving the hospital have cognitive impairment. And that's, for about half of those at least, it's temporary cognitive impairment, that it gets better. But being sick and being in the hospital does cloud one's cognition for many people. And those rates are actually even higher when you get into specific populations, such as elderly with heart failure. The rates of cognitive impairment in that population exceeds 50%. So we have to keep this in mind, that it's not even just about the baseline skills, but in the context of being in the hospital, things get much worse. Next slide. As part of preparing for this presentation, the planning committee asked me to talk about the mechanisms by which this is important. And I created this simplified diagram, or mechanistic pathway, which you can see over on the side, basically Ruth Parker's arrow diagram turned on its side, where you have the skills and ability of the patient interacting with demand and complexity, which I have replaced with after-visit summary or discharge instructions, which is part of the very focused part of the healthcare system that we're discussing today. And those really meet together and begin to have effects on knowledge, new skills, and self-efficacy for the patient, which we hope leads to behaviors which we hope are advantageous, which could lead to better health outcomes. Of course, if this is done poorly, it could lead to lower self-efficacy and worse behaviors and worse health outcomes. And I will come back to this mechanistic pathway in a little bit. Next slide, please. A few weeks ago, as I was preparing for this presentation, I had a couple of patients that I wanted to tell you about, and these are my primary care patients. One, next slide, please. One is a patient that was in the hospital and had just been discharged, and I was working with this case. None of these names or descriptors are, none of the names are real to protect the identity, but I have a patient who's a 60-year-old male who's a former actuary who retired down here to Chapel Hill with his wife. He has diabetes, coronary disease, heart failure, kidney disease, and depression. He's really sick, and I spent a lot of time taking care of him. About 6 weeks ago now, he was admitted to the hospital with chest pain and shortness of breath, and had a heart attack, and was in the hospital for 8 days on the cardiology service, during which I went by to see him. I talked with the team about his discharge and the plans. Next slide, please. So we should be on slide 8 now, and I'm going to give you, go quickly through this. These are the discharge instructions that my patient had. And I don't need to dive into this. You can see that this is the medication list, difficult to sort through with very small font, and I can assure you that this patient left with some substantial cognitive impairment at the time of his discharge. He has difficulty with mobility and an overwhelmed spouse. And I can also tell you that this is from our hospital, and we are converting in about 2 weeks over to Epic and redesigning our discharge instructions, but this is what we've been giving out lately. Next slide, please. I know that you probably can't read the details on these slides, but this is where we get into the reason for the hospitalization. And you can see here one of the paragraphs starts to say, if following discharge from the hospital, notice development or worsening of any symptoms such as nausea, vomiting, chest pain, shortness of breath, fevers, or chills, please return to the emergency department. It goes on. So in here are some important content sort of buried in here that you'd have to read through, and I can guarantee you that most of my patients are not referring to this information. Reading something like this is not particularly appealing for a medical patient that's still recovering from illness going home. You can see, in addition to the medication list, there was some discussion of dose changes and new medications and medications to stop. These are all good things to be talking about with a patient. Next slide, please. I'm sorry if there's a delay. I'm trying to watch my slides on the webcast, and it may be a little bit slower. Here you have additional instructions on fluid management, instructions about from your outpatient provider, which technically is me, but these instructions didn't come from me. And you see on some coronary disease instructions, some heart failure instructions. Next slide, please. Let's go on to slide, and we can skip this slide. These are home health orders that were in there, and on to slide 12. So the question for you, I have a 60-year-old male with complicated medical problems with cognitive impairment, fatigue, and anxiety between he and his spouse. Fatigue and anxiety also occurring in his spouse, although not the cognitive impairment. Will the patient or family be able to, will they make a mistake? What are the chances? And which parts of the summary are important? And who should figure that out? Who should figure out what the important parts are and what the patient needs to know and needs to do? Next slide. My next patient is Jane, who is a patient I was seeing in my primary care office one day. She's a 64-year-old female with high blood pressure, rheumatoid arthritis, osteoporosis, and a recently ruptured hand tendon. And this is to describe the context of an after-visit summary. Her blood pressure is high, and I need to increase her medicine. She's having surgery at the end of the month and having hip pain today with substantially less range of motion on exam than what I've seen before in her. Next slide, please. And in the context of this discussion with the upcoming surgery, the patient said, well, the surgeon told me to stop taking tofacitinib, I can never say that name. She actually told me in the trade name, which I didn't want to put on the slide, and naproxen before surgery. I should stop all my medicines before surgery, right? And then she also asked, she said she didn't want to undergo the surgery and wanted to know my opinion about whether she should or not. We actually discussed that, and I advised that I thought it would be a good idea. But next slide, please. So you can see that in the context of what I have is a luxurious 20-minute visit with a patient, routine primary care visit. There's a lot for me to cover. I had to, and this is for me summing it up, I increased the blood pressure medicine, which I discussed with her and actually asked her to teach back what she was going to do. We went through the medication instructions related to surgery, and I asked her to teach that back. And then I said, well, we've got to make a plan for your hip. I'm going to get an x-ray, and depending on what the x-ray shows, there are two different paths depending on those results. If it shows this, I'll do this. If it shows that, I'll do that. Next slide. So how do I put together this after-visit summary? In most after-visit summaries, including at UNC, you have the requisite problem list written here in all caps about problems the patient may or may not even understand that was one of their problems because of the words we use. Medication list, I think, is generally a good thing. I'm not sure that the format here is particularly helpful. Next slide. Our after-visit summary also includes the recent visit dates, vital signs. I left the blood pressures on here so you could see her blood pressure was high. And then what I have is what Alex pointed out, my visit notes. So these are the areas where I get to type in. And this is what I typed in for this patient in terms of the plans that I just discussed with all of you. I didn't send this to Alex to run the literacy screen on it. I don't know what reading level. I'm typing this in the context of a quick visit, and I try to do a good job. I'm probably, most of you know me there. I'm particularly sensitive to health literacy issues and try to do a very good job communicating in easy-to-understand language. But you can see even here, you might find ways that I could have written that better in the context of a quick clinical visit. Next slide, please. So there are several different medical problems and several different plans for this visit. If I did not write this down, so this is the good thing, having an after-visit summary. If I did not write it down, would she have remembered all of that? What are the chances that she would have forgotten one of those things, which medications to take for surgery or which what she's going to do with her blood pressure medicine? If I just gave her a new medication list alone, would that have worked? My argument is that she needs a little bit more specific information about what changes I made, not just a new list. Does her problem list help her with any discrete tasks? I don't think it helps with any tasks. In any other ways, well, maybe it's helpful to refer to know what's in your medical record. I believe that there is probably some benefit to giving out the problem list for that reason. Should I have also given her a brochure on high blood pressure or hip pain? Would those have helped? I'm not sure. I know when we convert to Epic, I will be able to draw in information from HealthWise, which could give her information on high blood pressure or hip pain, which would add to the visit summary that I just showed you. Next slide. So I really wanted to walk you through these cases because they are they're what we deal with in the clinical setting, and I think that sets the context for how we can design a better discharge instruction or better after-visit summary.
Darren, you have about 5 minutes.
Thank you. I thought I was going to be off the hook on time because I couldn't see you. Okay, so let me get back to the link between good after-visit summary and discharge instructions. Next slide, please. This first picture is of the chronic care model. And the point I want to bring up here is we do all of these things up in that green oval, including decision support, self-management support. All of that is set up to create productive interactions between the patient and the care team. And I really view these summaries as part of those productive interactions. And I'm afraid that right now, they're not as productive as we would like. Next slide. And on slide 21, you're going to have to click a second time to bring up some red lettering that I put on here. What I would argue is that on the after-visit summary or discharge instructions, if they are poorly designed, then we're probably not going to increase or decrease knowledge. We're probably not going to increase or decrease new skills. I do think we decrease self-efficacy when we present something that's overwhelming. I think it gives patients more of the impression that they're not in control or can't manage this. Consequently, I believe that these could have an adverse consequence of making it more difficult to carry out optimal behaviors. Next slide. But I do believe that with good or well-designed, that we have an opportunity to improve knowledge, skills, and efficacy, and behavior and outcomes. And I think that's the spirit with which policymakers have come into this. And I believe it's really our job as health systems and as activists and at the Roundtable to try and help to turn this into a win for our patients and our health system. Next slide. I titled this a piece of paper, and my research fellow commented that it's not just a piece of paper we're talking about here. There are electronic versions of these, and Josh referred to that as well. However we're delivering it, it's a reference tool for the home, and we know. I don't think we're guessing anymore. We know that patients will forget what we discuss. in the clinical setting, whether it's discharge from the hospital or the outpatient setting. And so if we don't write it down, we know that there's a really good chance it's going to be forgotten. We know it's actually forgotten a lot even if we do write it down. So the piece of paper is very important, and I think it's necessary, but it's probably not sufficient. It has to be put into the context of an overall care plan that provides reinforcement. Next slide.
2 minutes.
I'll make it. The piece of paper is important. Let's see. I lost my slide there. Okay, I think we're on perfecting the dismount. I think we missed a slide. Could you go back one, even though I only have 2 minutes? Yeah. One thing is, I believe that if you give more than 2 instructions, it won't likely be remembered unless there's written backup. And at discharge, patients may remember even less than that. And I also believe that these instructions need to be specific. So take this medicine at this time, call for these reasons, eat these things. Very specific. Next slide. This next slide I labeled Perfecting the Dismount. And I really think that in doing this work, we need to give the patient what they can handle and give the family what they can handle. And this means it's probably not a one-size-fits-all. We really need to arrange for others to help. Home health agencies, particularly at the discharge from the hospital, are critical here, and we need to hold them accountable for providing this help. The other thing that we need to do at this time is to estimate the interval for additional guidance, which could include future clinic visits or phone calls, and we generally underestimate the need for that additional guidance. We often discharge patients saying, see your doctor in a couple of weeks or a month, when they really need to be called in 2 or 3 days or seen in clinic within a week. And I think we're moving that direction, but we still make that error a lot. Next slide. This is not an IT solution only. We need to change how we think, and we need to change how we distill and present instructions. If you could click one more time on this slide. We've been trying at UNC to ask the medical team, what are the 3 things you want this patient to remember about their self-care at the time of discharge? And they can't do it. What are the 3 things they need to do or look for? We've had an incredibly difficult time because we haven't been thinking this way about how do we distill and present these instructions. So beyond just this piece of paper, we have some work to do in helping reframe how we think about handing this information off to our patients. And on to my last slide. In summary, I think we know, and Alex covered this very well, most hospital discharges and clinic visits have some need to know and need to do instructions, but they're hidden. These discharge instructions and after-visit summaries are the avenue to communicate these, and they're typically difficult for patients to understand and use. And so I really believe in my heart that improving this communication to the patient is a critical piece of healthcare, and that we have a big opportunity now to make a difference for patients in every interaction with our healthcare system. Thank you.